Hey folks, Scott Weingart here, and this is the EMCrit podcast. I am so sorry this is late. Things just kept happening in terms of the research. I just kept wanting to read one more paper. I think I'm finally ready. Today's episode is on THAM. THAM is a better buffer. I mean, it's not better in every circumstance, but it's better in a lot of circumstances than sodium bicarbonate. THAM was a medication I was using when I had first come to Stony Brook, and then, I loved it. It was having really wonderful effects. And then they just took it off the market. And unbeknownst to me, it came back on recently, a couple of years ago. And I didn't know this until I was talking to my buddy and EMCrit team member, Trina Augustin. And she's like, yeah, we got it back. I'm like, what? And then I'm like, I need to do a show on it. Now, in all things that I don't consider myself a third level expert on, I always want to have the backup of a guest who is smarter than me on the areas that I am flagging on. And for that, it's always going to be pharmacokinetics and dynamics of medications. So I wanted to get a pharmacologist on, and I got a brilliant PharmD. I got Patrick Budershevsky on. You'll hear from him shortly. Now, before we dive in, I just want to mention a conference I'm going to be speaking at, and it's the Incrementum 2025 conference. And this is filling the huge smack-sized hole that has existed in my heart since SMAC became defunct. These are a bunch of super enthusiastic Spanish emergency medicine folks who want to put on a conference that is similar to SMAC. The good speakers, the interesting lectures, beautiful place. They are holding this in Murcia, Spain, which is outside Madrid, some of the best places in the world. It's going to be beautiful. Folks from the St. Emlyn's crew are coming. All your USA buddies are coming. It just looks beautiful. And I'm not making any money from this conference. I'm just speaking at it. But I'm like, I want SMAC. And there was no SMAC to go to each year. And now this looks like it's going to be the one. They're offering a discount for EMCrit members. You can find information on that by going to the show notes for this episode. But I think you should check it out because I think it's going to be kind of a great conference. All right. Enough of that. Let's dive right in talking about THAM, which is the buffer of choice when the patient can't blow off excess CO2. Who are you and what do you do?
Right. My name is Patrick Budershevsky. I'm a pharmacist at Mayo Clinic in Rochester, Minnesota. I practice in the cardiac surgery intensive care unit and I'm part of the ECMO program here.
And you were also a co-author on a recent systematic review on THAM, which is what we're going to be discussing today. What is your interest in this medication, Patrick?
That's right. I actually have a lot of interest in THAM. I think it's a really curious drug that is probably heavily underutilized, but has been around for quite some time. It really has an interesting history.
So let's talk a little bit about THAM. So first of all, what is it?
Yeah, so THAM is a small molecule. It's a inert amino alcohol and has a very high buffering capacity. So it has a buffering capacity that's a bit higher than bicarbonate. THAM works by direct protonation. And so acids protonate the THAM molecule, which in a way buffers the acid. And then that protonated THAM complex is excreted by the kidneys. But with that is excreted.
All right. So what I'm going to be doing in the course of this piece is interspersing, along with my discussion with Patrick, my own take on this stuff, now having done just an insane amount of research on THAM, in addition to my own clinical experiences before it disappeared from the market. So, mechanisms of action of THAM. We mentioned this, but let's really hit it. So, there's basically two modes of action THAM could take to act as a buffering agent. It can take a carbon dioxide molecule and a water molecule and augment the splitting of those to actually protonate the THAM, meaning one of the hydrogens goes onto the THAM molecule, and now it becomes THAM plus. And then the remainder goes and forms a bicarb. So you're generating a bicarb from a carbon dioxide. So you're just eating carbon dioxide and pooping out bicarb. Seems pretty ideal for a buffer. Or it could directly bind a hydrogen ion and then just form a protonated THAM. So it just takes the H plus and links it up to the THAM molecule, and now all of a sudden you have a positively charged THAM molecule. So you can see these two equations in the show notes. Now, from a Stewart perspective, and as the quantitative approach to acid base is my approach to acid base, What this is essentially doing is adding a new additional independent variable to the mix from our standard weak acid, CO2, and strong ion difference. It adds weak bases, because that's essentially what THAM becomes, is a weak base. And therefore, you will make the strong ion difference bigger. That's what THAM's essentially doing. It's adding an unmeasured cation to the mix. All of a sudden, you have another positively charged thing hanging out that's going to augment the strong ion difference and therefore make the patient alkalotic. All right, let's talk a little bit more about dosing. So as Patrick mentioned, the US form of THAM is a 500 ml bottle that contains 300 millimoles per liter of THAM acetate. And that is 36 grams of THAM per liter, or 18 grams of THAM per one of those 500 ml bottles. And again, this is all in the show notes. There's a lot of numbers to take in. So what you want to just remember for now is the dose form you're going to be given that's equivalent to what you'd be giving with a bicarb is, instead of 1 amp, you're going to be giving half to 1 bottle. That's going to be your dose form, half to 1 of these 500 cc bottles. Now, the acetate that's in there is also beneficial, because unless the patient's anhepatic, that acetate is going to be formed into another bicarb when it gets metabolized in the liver. We went a little bit in dosing, and we mentioned that formula for how many mLs of THAM to give, and it's lean body weight in kilograms times the patient's base deficit times 1.1. I don't think you're going to be using that formula very much, honestly. I'm going to give you a better way in just a second. The maximum daily dose is 15 millimoles per kilogram. That's your daily dose for an adult. What does that translate to in numbers you can understand just listening to me? 3.5 liters, 7 of those 500 cc bottles in a 70 kilogram patient would be your max daily dose. Now, you can give this as a loading dose, as a rapid bolus. One of the papers mentions intravenously over 5 to 10 minutes. You could give 25 to 50% of your anticipated full dose, and then you could give the rest over an hour. We'll go into adverse effects and whether they really exist in just a little bit, but obviously, if you gave too much of this rapidly, then if there are adverse effects, they're going to be more likely to happen because you're just giving it in a much quicker way. The maximum daily dose probably shouldn't be given in 1 hour. So you shouldn't be given those 7 bottles of THAM in 1 hour, even though it's still underneath the 15 millimole per liter, 15 millimole per kilogram dose. All right, so in some of the studies, in a set of APOX studies, they were giving this drug 0.5 mLs per kilogram per minute for up to 10 minutes. And it was just being used to buffer the CO2. So that's much more rapid than a slow infusion. And then after those 10 minutes, they cut down the dose to 2 millimoles per kilogram. In 1ED, and this was published on Allium, and I think this is probably the most utile way to approach this. This is by Dr. Sur. If I'm mispronouncing that, I greatly apologize. But the post is linked in the show notes. And for them, they would just basically give a 500 cc dose and then recheck labs. And they'd give the first 250 cc's of that as a bolus. And that could be just let it run in, because that'll probably take a few minutes. Or I think in certain circumstances, like cardiac arrest, as we'll talk about shortly, I think you could give it even quicker, those 250 cc's. And then they'd let the remainder of the 250 cc's left in that bottle go in over the next 30 minutes. And then they would recheck blood gases to see where they stand. I think that's a very utile way of approaching this medication. So, yeah, let's stop there and go back to the interview. And so then that would bring up another question I had, which is in patients with renal failure, they're not excreting this. What is the net acid-base effect in that circumstance?
So I think you would still get some buffering effect, but I'm not sure that it would be as optimized as someone who is actively excreting it. There's also a concern that there's some concerns that if you give THAM to someone with impaired renal function where you're not excreting the complex, that it would have detrimental effects, but it really has essentially no physiologic effect outside of buffering acids.
All right, let's talk a little bit more about this elimination. So THAM does not penetrate the intracellular space very well. It eventually gets there a little bit, but most of it stays in the plasma and the extracellular fluid. This is interesting because it means you're actually creating a CO2 gradient that will cause CO2 to move out of the cells in contradistinction to sodium bicarb, which causes intracellular acidosis. It causes intracranial acidosis because it's generating CO2. That CO2 actually diffuses into the cells. THAM is going to draw it out. It's excreted in the urine in its protonated form primarily. And if the patient's acidotic, it's actually going to take a chloride with the excretion. This is how it's going to have durable effects on the patient's acid-base status. It's going to keep them alkalotic because even in excretion, it's not going to reform those anions. Now, in a patient who is anuric, what will actually take place? Now, if you analyze this from a Stewart approach, you're not going to lose the alkalinizing effect of the THAM just because it's not being excreted. What will eventually happen is you'll have a lot more THAM building up in the bloodstream. Now, I don't know why this would be too much of a problem, except I guess there's twofold issues. I don't know if they're problems, but issue one is more and more of this, if it just hangs out forever, will eventually penetrate into the intracellular space. I don't think this is necessarily bad, but it is going to have intracellular effects that sodium bicarb won't. I don't think there's any actual problems with that. What will happen is a progressive shift towards THAM taking up osmolar space. And eventually what happens, just like when you have lots of glucose hanging out there, is you will get a pseudo-hyponatremia. And when I say pseudo in this case, I don't mean it's a false reading of the patient's sodium. The patient's sodium will just go down because you don't need the sodium there to maintain the same osmolality. And as a result, you'll see some degree of hyponatremia. But this is not a hyponatremia that is making the patient actually hypoosmolar, right? Just like glucose will leave them hyperosmolar in a DKA or a hyperglycemic hyperosmolar type situation, HSS. But the THAM shouldn't really do that to the same extent. But you will see the numbers on the sodium go down. Aside from that, I don't really see what the issue is with this accumulation, except maybe for some glucose effects, which we'll talk about shortly. THAM is dialysable. And so that might, if you have a patient who's anuric but on dialysis, then that's probably not an issue either. So really, it's just a question of the patient who is anuric and not on some form of continuous renal replacement, whether that matters or not. All right, let's jump back in. All right, so in essence, when we give sodium bicarb as a buffer, we're generating CO2. And if you couldn't get rid of that excess CO2, then essentially you're not doing very much for buffering. And it's fine on patients who can increase their respiratory drive. It's going to work the way you expect. But in patients who are, in essence, what we call a closed system, meaning they're already excreting as much CO2 as they can, it's not going to have a great effect. THAM, on the other hand, will continue to buffer. And in fact, THAM could be used for a respiratory acidosis patient in contradistinction to sodium bicarbonate. So I was using it, and then it disappeared, much to my chagrin. And it wasn't until I saw your paper that I realized it was back on the market because our hospital just stopped stocking it. What's the deal? What's the history of this? When did it come about and why did it disappear?
Yeah, so I got into a little bit of a rabbit hole when we wrote this paper. So THAM was actually approved in the mid-1960s. It received FDA approval. I believe the indications have stayed intact since then. They haven't changed. So technically it's FDA approved for treatment of metabolic acidosis in the context of surgery that uses cardiopulmonary bypass, for acidosis that's associated with saturated blood, and also acidosis in the context of cardiac arrest. So approved in the 1960s, had been used quite a bit over time, and somewhere around, I think the early 2010s, it just disappeared. There was a shortage, people couldn't get it, and then in 2016, it appeared on this discontinued drug list. So it's the Orange Book of discontinued drugs. And I guess somebody saw that. And so they submitted a petition to the FDA inquiring about why it was discontinued. There was some concerns that maybe it was because of lack of efficacy or some safety issues that weren't announced. And the FDA actually responded at that time that it was just the manufacturer just decided to stop making it. There was no safety issues. There was no efficacy issues. They just stopped. And then it was right around the beginning of the COVID pandemic where they just started making it again. And it's been available for 4 years now since they resume that manufacturing. I guess to tie back into your earlier question, why I have an interest in this is because during this time, over the past 15 or so years when it was not available, we were actually producing it in-house. And so we have a compounding facility that mainly produces products for us to use in-house, obviously accordance to manufacturing laws. But since the drug had an FDA approval and it was not available on the commercial market, you could compound it and use it. And so we were making it throughout that entire time and acquiring quite a bit of experience with it.
That's super cool. Now, are you guys still compounding it, or are you buying it now from the official manufacturer?
Yeah, so we have to buy it. That was one of my questions too, because to my understanding, it's quite cheap to make, but it's not that cheap to buy.
That was going to be my next question. Any idea? Each hospital is obviously going to vary depending on what they negotiate, but if you just had a general idea, how expensive is this?
Yeah, so I looked at the average wholesale price this morning, at least the public information that I could find. And in comparison, a bottle of 18 grams, 500cc bottle of 18 grams of THAM looks to be about the same price as about half a day of vasopressin infusion.
Okay.
So I thought that was something people could relate to, maybe.
And just so I get a real comparison in my mind, what is a half a day of vasopressin at your place approximately?
So an average wholesale price, which are public numbers, around $300-400.
Okay. And this gets us to our next question, because this is all over the map. What is a dose of THAM? And an idea of what we could do with that 18-gram bottle.
Yeah. I think this is something that is controversial. There's not really a set dose. There is a equation that you can use it goes back decades. You essentially take the base deficit, you multiply the base deficit by 1.1 and multiply it by the body weight. So body weight in kilos times base deficit times 1.1 would be the volume of 0.3 molar THAM to give. Coincidentally, in an average sized person with a base deficit around 5, it would be about 18 grams.
And so you're spending about 300 or 400, and then bicarb in comparison is just super cheap, if I had to imagine. No one's taking the market for bicarb at this stage.
For comparison, I looked at it, I think, again, these are like average wholesale prices, which I'm not even sure how that means in the context of everyone negotiating contracts, but it seemed to be about 1/10 the price.
That sounds about right.
Yeah.
All right, so we're talking variable dosing, but we have some idea now. And I'll refer people to your paper because it goes through the full range of the very scant RCTs and then also discusses some of the observational trials. And you'll see there's an enormous dose range when people take a look at that paper. But you've given us a nice starting point here. Hey, folks, but you know we're not getting right to the show because you're listening to the free foam feed of EMCrit rather than the members-only feed. Now, I'll put you out of your suspense. This is a full episode. You're not going to be cut off. Don't get upset that you're hearing this and now 8 minutes from now, you're going to be listening, super excited by what you're learning, and then all of a sudden, and no more episode. You never want to hear that sound again. You're not going to hear it in this one, but you're going to hear it in a bunch of others because you're not a member. And membership is so cheap and so beneficial to the care that you could provide your critically ill patients in the ED or ICU that it's just crazy that you're still hearing this message. So go to emcrit.org/join, become a member, do it before the end of the year. You could write it off on your taxes. You could use your CME funds. And then all of a sudden you get all of the stuff that is not available in the free feed, and you never have to hear this message again. Please consider joining, and thank you for listening.
We don't use it in people who are particularly mildly acidotic because you can buffer quite a bit and you could push the opposite direction. And we tend to use fixed dosing. So we'll use a full bottle at a time. And so our typical approach is base deficit of 5 or greater. Otherwise, you probably end up producing some alkalosis.
All right, just a little bit more about the effects of THAM. We already touched on the osmolar effects of THAM. What I should have mentioned there is you could actually monitor THAM levels without a THAM assay by looking for the osmolar gap. And this is interesting. It's very much like mannitol, where you could run an osmolar gap and actually know how much THAM is hanging out there, as long as you have no other substances concurrently running that would cause an osmolar gap. So I just thought that's interesting. THAM's effect on ICP Also interesting. THAM is definitely a better buffer in the CNS because sodium bicarb in a patient who cannot eliminate their CO2 will actually cause a brain acidosis because the CO2 will diffuse, but the buffering effect won't really occur there. THAM, on the other hand, can actually, since it's sucking up CO2, immediately cause a effect of what you want, which is a slight hyperventilatory effect, CO2 going down. But in a non-intact blood-brain barrier, THAM probably penetrates the blood-brain barrier and therefore could act as a buffer in the intracranial space as well. This has been studied, THAM actually reduces ICP. Now, the exact mechanism is probably a mixture of all of the above, but THAM reduces ICP. That's been seen in numerous studies at this point. So that is interesting to me. I've already mentioned the intracellular acidosis and the fact that bicarb makes it worse, and THAM makes it better. But what we should really say here is the problem with bicarb in a closed system is that you might look at it and say, even though the patient can't blow off the CO2 I generated, even though the patient either they're already hypercapnic or they're actually have a lower than normal CO2, but it's not enough to make up for the patient's acidosis, which means they really don't have any additional space to blow off more CO2, or else they'd already be doing it. When you see a patient with a pH of 6.9 and a CO2 of 25, like their body would much rather be at a CO2 of 8. And if they're at 25, it means they can't do it. They can't do it. And so if you gave bicarb in that circumstance, it's probably not going to be blown off. And yet sometimes you'll see the pH come up and you're like, yay, it still worked. It still worked in this closed system. And not so much, because we monitor pH in the bloodstream. What you saw when you couldn't blow off the CO2, but the bicarb still seemed to work, is that all that CO2 went to spaces you're not measuring. And that means the intracellular space. And you could argue back and forth about I don't think it matters. It does matter. But it really does matter in a patient who is critically ill with a profoundly low pH. Like their cells were already seeing the milieu of badness of a 6.9. And just because you gave bicarb and it went up to 7.1 and you're feeling all good about yourself, if they weren't able to blow off that CO2, the reason that happened is because a lot of that CO2 now went intracellularly. And that's not good. Even though we're not measuring that, even though like the numbers might look slightly better, the patient's situation has gotten markedly worse. THAM is going to make the acidosis in the plasma better. It's also going to make the acidosis in the cell better. Patrick, let's talk about the contraindications and adverse effects from THAM.
I'm not sure that there's actually contraindication. There's been some, we wrote about this in the systematic review, there's concerns about hyperkalemia, but it didn't seem to pan out with at least the available evidence that it's really that much of a concern.
All right, so the hyperk disappeared. There is still hypoglycemia.
Oh, sure, yeah. Yeah, so I guess you can have essentially like a hyperosmolar effect where you could produce like a really large hypoglycemia. There was one case report of that.
So do you folks put patients on some standard hourly or 2-hour glucose regimen when they're getting THAM, or what do you change to because of fear of this hypoglycemia?
Yeah, I would say that for me, I guess I'm not necessarily fearing it. And again, I guess my answer is a little bit biased because everyone that we're using it in is 12 hours out of cardiopulmonary bypass. And so their glucose is abnormal. They're on insulin infusions. And so we're already rapidly monitoring these things. But I guess you could intensify your assessment to ease that concern.
The other adverse event mentioned in the paper that's not relevant to the U.S. is the possibility of skin or tissue necrosis, the non-acetate form. Now, in the United States, the only form available is the acetate form of this. But if you had a THAM base in a different country, then is it central line only? Is it just not crappy IVs? Do you have any knowledge of that, Patrick?
I don't have knowledge of it, and I'm not sure that they would produce it anymore like that because the acetated form actually increases the pKa of THAM, and so it effectively makes it a better buffer. And so I'm not sure that it is even used at all. But yeah, I guess you would apply the same principles as anything else that is caustic to put it through a big vein or central if you can.
All right, let's talk about these adverse effects. The hypoglycemia one, all of these are really hard to pin down. I had to do a ton of research to even get suggestions of the mechanisms for these adverse effects. And so it's been really tough. Hypoglycemia. The some sources have said, oh, it's probably just an effect of the osmolar changes. And so you're getting a dilutional hypoglycemia. That seemed like garbage. In another set of studies, this was rat studies where they're actually looking for the mechanism. It seems to have an insulin-like effect in terms of the utilization of glucose by skeletal muscle, and that insulin may even be synergistic with the THAM. The amount of hypoglycemia is not enormous, but I do think it bears watching. And I don't know. I think if I was using THAM for anything more than a modicum dose, I'd probably put the patient on Q1 hour finger sticks while you're actually giving the medication. I think once it's in, you've given them some time to settle. I think you're good, but I think that's probably worth it to just do 1 or 2 sets of finger sticks because we don't quite know what's going on here. Most of the studies did not say, in adults at least, that this is a big deal. All right, the hyper K. As to whether this even exists is disputable depending on which studies you look at. It was a real rabbit hole for this one. I still can't find a mechanism. If anyone knows or posits a mechanism for why THAM causes hyper K, let me know. The closest I came was a paper saying the acidosis probably causes a huge release of endogenous catechols. And when you give the THAM, it's all made better. So those catechols go away. So all of the potassium that was forced intracellularly by the patient's endogenous epinephrine all of a sudden will come out. Well, that doesn't make any sense because that should just bring them back to normocholemia. And even if you had done potassium repletion in the midst of that, we should have seen the same real effects in bicarb. Like it doesn't, I don't buy it. I don't buy that's the mechanism. If it even exists, maybe the reason we can't find a mechanism is it doesn't actually happen. There was one paper in Respiratory Care, this is a journal for respiratory therapists. It was just an abstract, so nothing, like no methods or anything, where they did a retrospective study and an occasional patient, like very few by percentage, had a 1 milli equivalent per liter increase in potassium. I don't think you have to worry about this. I think the way to play is when you're getting your blood gases, make it a blood gas that has electrolytes on it so you just see the potassium. But I think you're going to be fine, to be honest, like from the hyper K perspective. All right, we already mentioned in renal failure that it will accumulate. And I already mentioned that is going to cause a pseudohypoglycemia. And again, I don't know if that's really a problem or not. It's just something to be aware of. So that's really the adverse event profile of THAM. Now, there's one more to mention. In healthy volunteers or patients who probably didn't need it, if you gave THAM rapidly, you could cause apnea. Now, this is solely because you lowered their CO2. And my guess is, okay, so they stop breathing, but their CO2 is going to rise. And then they'll start breathing again. This one didn't bother me. Like I didn't even initially put it in the show notes. I think it is worth just watching the patient immediately after giving the THAM because the results should be instantaneous and just make sure like they don't have prolonged apnea. But in the patients we're going to be using this in, I just don't think that's really a worry. We actually are giving it because they're so acidotic that we want them to get back to an alkalotic state. So if I slammed in 500 cc's of THAM to you, you might stop breathing for a while. I think it's going to be a self-limiting event, honestly. And if you're on supplemental oxygen, I think you could stop breathing for an extended period of time and it's not going to matter. But just be aware that apnea has been associated with THAM because it's working, not because it's a true adverse event. But just be aware of that. Okay, back in. Sounds good. And now you said at the Mayo, you folks will give 1 bottle. Now I assume you're going to recheck some form of blood gas. Is there any spacing between you giving another dose at that point? Like what is your second dose regimen?
Yeah, I would say 30 minutes to 2 hours is a reasonable time to reassess. And that's largely in line with these papers that studied THAM use. They're checking it quite rapidly. You would expect a quick buffering effect.
Yeah, it should be instantaneous. And is there anything else we missed that we should talk about on THAM?
We talked about who we shouldn't use it in. I think an interesting thing to maybe circle back to that is who we should use it in.
Yeah.
And like why use it instead of bicarb? Because that's usually the question is, well, bicarb buffers, like why not just use bicarb? You alluded this a little bit earlier about someone who has a metabolic acidosis and maybe a respiratory acidosis. And I think that's one of the main big drivers and motivation for why it's attractive is really it does not generate dissolved carbon dioxide. And so if you're not generating dissolved carbon dioxide, it can be very useful in people who have these concomitant acidosis, who you're treating for ARDS and you're providing permissive hypocapnia and you have a respiratory acidosis. Bicarb is going to make that worse. And so I think not generating dissolved CO2 is one of the big drivers of how it can be useful. One of the other contexts that we were actually quite interested in is in liver transplant. You may have saw some of the papers that we reported in that systematic review that use it in liver transplant. Liver transplant's a really extremely interesting use case for it because these patients with chronic liver dysfunction have hyponatremia, and when they take the liver out and are anhepatic and reperfuse the liver, they have massive electrolyte abnormalities, acidosis. If you give bicarb to treat all that, you could produce rapid shifts in sodium. And so using THAM to prevent those shifts could actually be beneficial in those patients.
That's interesting. One of the other indications you mentioned from the FDA was cardiac arrest.
Mm-hmm.
And this would seem to be much more clever than sodium bicarbonate because the CO2 is just not going to be helping.
Yeah, you can't blow it up.
Yeah. So have you run across any literature that would support that? Do you know anyone who's doing that? Are you folks at the Mayo who are compounding your own THAM up until recently? Are you administering this to your arrests?
Not routinely. It's just not easy to get your hands on in a fast manner. Bicarb syringe is easy. You just twist it and push it.
All right, let's talk about some clinical uses and indications for THAM. Aside from just I want buffering in a patient that can't blow off excess CO2, which I think you could give to any of those patients. But there's some specific circumstances been used in the literature. Used in sepsis, the pH increases without increases in PaCO2, just as you'd expect. And it also causes a diuresis. So if you want to diurese your patients, great, but be aware it is an osmolar diuretic, just like mannitol. In patients with intact kidneys, you might want to monitor that. Now, most of our septic patients, that's a bonus, not a bug, but just be aware you might get an osmolar diuresis. Cardiac arrest. This is super intriguing to me. I think now that we have literature saying bicarb doesn't work and may actually be deleterious during cardiac arrest, THAM becomes really intriguing to me, especially if you give it as a 250 cc rapid infusion or even a slow push. This could be super intriguing. Now, before I gave it, I'd probably want to know the arterial pH. Now, this is key because, look, I'm the biggest fan of VBGs in almost every circumstance, but there's a discrepancy that occurs in cardiac arrest where you might be profoundly acidotic on your venous side, and that's usually the one you want to get because it reflects what's happening intracellularly to some extent. But you can have a paradoxical alkalosis or normal pH on the arterial side. And it's just due to the fact that so little the oxygenated blood from your lungs is actually being taken up during cardiac arrest state that you could have a alkalosis on that side. There's a disconnect between the venous and arterial sides during cardiac arrest. So I think I wouldn't give this THAM unless I already had an arterial blood gas, point of care preferably, that told me, yeah, the patient's actually at the phase of their arrest where they're acidotic on the arterial side as well. And then I probably would, and I think I'd probably start doing this on patients who you feel have viability, because it's not a cheap medication, as mentioned. It's not super expensive. It's not thrombolytics, but it's not cheap. But I'd probably give these patients a 250 cc rapid infusion of THAM, because we know the heart, when it's acidotic, is not going to go into a shockable rhythm or be able to be shocked out. So you're shooting for a pH of at least 7.2, and this might be a way to get there. So I find this really intriguing. And again, this is an FDA indication for THAM. Most of the other stuff is off-label. This is actually something that's approved for. All right, hypercarbia in acute lung injury with permissive hypercapnia or asthma in cases where the pH is just getting to a point you're a little bit scared. This makes complete sense. THAM seems the ideal agent, and using bicarb makes absolutely no sense to me in those situations. All right, what else should we talk about? I have some interesting studies here. There was an operative study where they did a head-to-head of bicarb versus THAM, and it's interesting. They basically had the same buffering. In this trial, they increased the ventilation to keep the CO2 constant. So all of the problems of bicarb disappeared, but it worked in both patients. In both of them, it generated bicarb. So bicarb generated bicarb, THAM generated bicarb, just as you expect, by taking up CO2 and generating bicarb. you could use THAM to set up a CO2 dialysis situation. That's another interesting study because now you could give THAM, and since it gets dialysed off and you take out that CO2, it's now been converted to bicarb, and you dialyze it, all of a sudden these patients have THAM CO2 dialysis without having to do extracorporeal CO2 removal, which we don't even know if it's beneficial. The studies have not panned out, but this would work without the mechanical complications of an ECMO circuit. So THAM dialysis allows you to dialyze CO2. There was another ICU study head-to-head, and these patients, again, were able to breathe off their CO2 because, look, I think bicarb will work just fine in an open system. Open system means patients capable of getting rid of the excess CO2. We know it works. That's fine. Use the cheap stuff. You're going to have problems with eventually with hypernatremia, hypokalemia, etc. But, use the cheap stuff. But when they can't blow off CO2, that's when THAM shines. And I've not seen any head-to-head trial of that. That's what we want. We want a group of patients who can't blow off any additional CO2 than they're already doing. Let's see head-to-head bicarb versus THAM. That would be super interesting. The last thing I'll leave you with is that there was one study and this was just an isolated heart model, so it's not like what we'd want a clinical study, but I think it's the really intriguing thing, is they used a combination of sodium bicarbonate and THAM. And wow, that makes complete sense because now all of a sudden, all of the problems of one get fixed by the other. So the excess CO2 gets eaten by the THAM, you balancing out the potassium stuff, if that even exists as a THAM complication. Everything looks good. This might be the way we eventually use it as a solution of sodium bicarb and THAM together. It's chocolate and peanut butter. It's everything good in the world, but someone's got to do a human trial of this. All right, again, check the show notes for all of the references, all of the numbers, everything. And let's jump back in with Patrick. Anything else we should hit on THAM?
I don't think so. I think if you can get your hands on it and try it, especially in these unique situations, it could prove beneficial for bicarb in some cases.
That's fantastic. I can't thank you enough for coming on. We will refer people to your paper because I think it's probably the best evidence out there on THAM right now.
Thanks so much for having me.